So invite you to attend. We have a lot of great panels coming up related to health equity, and all are welcome to attend. If you are planning to get CME credit, text this code, and all our required CME information is there. Today's speakers are listed here, and their disclosures are shown, as well as our learning objectives. And we're going to start out with, I know we're going this fast, but you'll be seeing it again. We're going to start out with a coronavirus update from Anna Samuels, and then we will get into our panel on ensuring health equity. So Anna.
All right. Hi, everyone. Welcome to our August COVID update. And there are updates. COVID continues to evolve, and the information does as well. So thank you for joining us today. Worldwide, we have over 21 million known cases with roughly 300,000 recorded cases per day. And we're starting to approach the 1 million number for global deaths, but not there yet. In the United States, this is looking at the number of new cases per day. We do seem to have come down from a peak over the last 2 weeks. However, still quite a number of recorded new cases daily. Texas, Florida, California, and then Georgia, in terms of volume, have the most numbers of cases being recorded. In Maryland, we are almost seeing like a second, we almost had like a second peak that might be coming down a little bit. We're seeing roughly 500 to 600 new cases per day in the last few days. Hospitalizations, looking at the purple and pink graphs, we had a bump in acute care beds occupied by patients with COVID and a stable low rate of ICU beds. So the ICU beds did not bump up in the same way that they did earlier in April, which is fortunate. And so we're kind of monitoring to see how this pattern evolves. Now, one of the things we are seeing is that the percent positives, and this is overall, so all the tests combined for whatever reason, is about 6%. Our testing volumes are quite high now, reaching over 1,500 tests per day done at our lab. As of yesterday, we had 29 people hospitalized at the downtown campus with 65 people hospitalized across all. Only 3 of them were on ventilator with COVID. 6 across all. And in the Children's Center, we had 5 total patients. So the young folks are compromising a proportion of this. In one of the dashboards, I was able to pull out this graph where admissions under 40 years old, the proportion of admissions, of people under age 40 is roughly 30. And this is distinctly higher than earlier in the epidemic. So we might be seeing more of the younger people now admitted as compared to earlier in April. In terms of MIS-C, we've reported 11 cases meeting CDC definition. Additionally, had 5 that we thought might have had it, but didn't quite meet that definition, for a total of 16 reported to the state. And just this past week, we've had 1 new case. So there was a lull for about a month, and now we're seeing 1 new case. We might see a few more if it's following the same pattern as before, with a delay of about 4 weeks from the peaks in the number of cases. Related to this, the CDC put out an article summarizing 570 MIS-C cases across the country. Our cases did factor into these that are summarized in this article. Interestingly, they did some statistical analysis trying to group patients, and they came up with 3 kind of phenotypic domains. One group was very ill, needing severe ICU critical care, and they almost all had positive antibody. A second group had predominant respiratory involvement, and most had a positive PCR that then kind of morphed into this MIS-C. So these might be people who actually get acute COVID symptoms and then evolve into MIS-C. And then the third were more mild and typically met the Kawasaki disease definition. So as this illness evolves, or we learn more about it, I think we'll have kind of think how this impacts our clinical care and our ability to recognize these patients early on. And then they also summarized hospitalized children in the United States. Of note, the rate of hospitalization is much lower than adults. However, among children, about 1 in 3 who are hospitalized go to the ICU. And this is felt to be potentially related to MIS-C. And so I thought those were some interesting epi articles to point out. Now, another major change that has happened in pediatric land and COVID is the change in recommendations to not separate infants from their mothers if their mothers are diagnosed with COVID at time of delivery. So in a large national cohort, there was a similar rate of COVID in the neonates, whether or not their babies were separated in the hospital. And there was some additional literature I'll point out. At this time, we will have babies room in with the mom unless the baby or the mom is too ill to be together. The mom and any other caregiver should wear masks and perform hand hygiene. Isolettes can be used as an additional barrier. We and the AEP support nursing and breastfeeding. We are still testing babies at 24 hours of life. Most do test negative. And then just a small thing, but in terms of our isolation guidance, our postpartum mothers can come off of isolation if they're otherwise improving after 14 days. Some places use a minimum of 10 days, and citing longer durations might be appropriate. So for us, it's 14 days. These are 2 related papers to point out. One is from JAMA. They looked at close to 80 newborns born to moms with COVID, and a couple of them tested positive right near birth and then cleared their tests. None developed symptoms, and 2 that did develop symptoms later on and test positive cleared within 48 hours, so very mild cases. Another paper more recently in The Lancet looked at over 100 neonates that did room in with their moms as well. At about 1 week, they all tested negative, and the ones they had follow-up at 2 weeks also tested negative. None developed symptoms. So these are all reassuring things that babies might do well even if their moms have COVID. However, we do know from case reports that some babies might be at risk for severe illness. So the infection prevention measures such as wearing masks and hand hygiene remain important. Those new algorithms for Hopkins are updated online. A few more updates before I pass along. So we have updated our isolation discontinuation isolation discontinuation parameters to more closely mimic that of the CDC's recommendations. So uncomplicated cases that are improving, generally 10 days. Complicated cases, those going to the ICU, immunocompromised patients, pregnant women, and group care settings are 20 days. If people are returning within 90 days of having a COVID positive test, they are asymptomatic from a COVID perspective, they don't need to be retested. If they are coming back and have symptoms that could be related to COVID, at that point we do recommend retesting and re-isolating them. If they are found to have another cause of their symptoms, they could come off of precautions. And some of the rationale for this is that we know that patients can have COVID positive PCR for up to really 3 months. And in our experience in published literature, typically after 10 days, the virus is no longer able to be cultured. And even among those with severe illness or immunocompromised conditions, their virus is typically not able to be cultured either. There have not been clear evidence of secondary transmissions or to either household contacts or healthcare workers when people are exposed to COVID after the first 6 days of illness. And it's still not clear that you can get reinfected, but this remains kind of a possibility, and therefore we still have this approach of if you have symptoms, reconsider COVID, but if you don't have symptoms, you can move on. I'm just going to remind people that people can have an incubation period of 14 days. So if your patient screened negative at admission, that doesn't mean they can never get COVID. So please be mindful of evolution of symptoms and flagging that patient as a PUI if they do develop symptoms concerning for COVID illness. And our PPE guidance really is here to protect you and our patients. So all of our encounters require a mask and eye shield, and aerosolizing procedures require respirator and the other items. So staff who cared for patients not wearing the recommended PPE might have increased risk of exposure, and depending on the exposure, you are at risk for being furloughed because of that. So please do be mindful and protect yourself. And let your supervisors know if you're encountering issues with logistics of PPE. Most of our staff that have had COVID really did have social contacts or household or other social contacts that led to their infection. However, we want to be very careful at work so that work is not an exposure to our healthcare workers and we are all safe. And last point is bandanas, neck gaiters, and masks with valves will no longer be a supported mask type or face covering type. They might have inferior protection as compared to other types of masks. So basic cloth masks or procedural masks are the way to go. Please help your colleagues or patients find an appropriate mask if they need an alternative. And with that, I will stop. Have a great day. Thank you so much.
Thank you so much, Anna. So getting into our Grand Rounds topic for today, we have two inspiring speakers talking about two timely innovations to ensure health equity. I'm going to introduce them one at a time, and then each will speak for about 15 to 20 minutes. And please save your questions till the end or put them in the chat, because we'd love to have a discussion and answer questions at the end of both speakers' presentations. So our first speaker, he's going to screen share, I think, is Alistair Martin. And he is a physician instructor at Mass General Hospital and at Harvard University in emergency medicine. He is at the Center for Social Justice and Health Equity at Harvard and has been a real innovator and founder of a couple of really great programs. One is he is a founder of Get Waivered, a campaign aimed at transforming emergency departments nationwide into the front door for recovery for patients with opioid addiction. And this work serves as a national model at the NIH and with other state partnerships, including Get Waivered Texas and Get Waivered Nebraska. And his work has received a lot of attention, but that's not what he's going to talk about today. He came to Harvard after working in state health policy and after getting a master's in public policy from the Harvard Kennedy School of Government. He was a fellow at the Center for Public Leadership. He was also a health policy aide to Governor Pete Shumlin of Vermont. And has also worked in the governor's office building the communications plan for Vermont's proposed single payer plan called Green Mountain Care. He previously was a chief resident at Mass General and the Brigham, and he now leverages his background in politics, healthcare policy, and the field of behavioral economics to use the emergency department as a place to build programs that serve the needs of vulnerable patients. And he's going to be talking about another program he founded called Vote ER. Really welcome Dr. Martin to Grand Rounds.
Thank you so much. Really appreciate that excellent introduction, and appreciate the opportunity to speak to you all today. Dr. Singh, if you could just do me a favor and go on mute on that computer that you're on, that'd be great. Thank you. All right. Why are we here? We have in front of us one of the most important elections I think any one of us is going to live through. And while it is important to make sure that we have our voices heard as providers, our patients' voices heard as providers, as citizens, for that election, I'm here to make the case that irrespective of if there's an election coming up in November 2020 or not, it's incredibly important for us to empower our patients, our providers, our colleagues, our friends, and our family to get registered to vote and to vote in this country. Why is that? As the late, great John Lewis said, the vote is the most powerful nonviolent change agent we have in our society, in a democratic society, and we must use it. And if we're not careful, we can lose it. We don't have time today to talk about all of the interesting ways that folks are engaging across this country to limit our ability to vote and to have our voices heard. But what we do have time to talk about today is the individual responsibility that we all have to use our privilege as providers and our privilege as a health care monolith, as institutions of health, to help empower folks to have their voices heard. First of all, why did I get into this? Let me tell you a story. It was 2 a.m. on a cold February night at Boston Children's Hospital. And I was a second-year resident at the time. And I had a young woman come to me who was in her probably early 30s at the time. And she had 2 kids with her, both younger than 3. And she said to me, "Doctor, look, you know, I've had a rough time over the course of the last 6 or 7 months, and I've had to move from another state to Massachusetts. And I got kicked out of where I was living. And I was couch surfing with my kids at my aunt's place here in Massachusetts. And things went left, and unfortunately, it just so happened that we didn't get along. There's a lot of friction, and she kicked me out. So over the course of the last week or so, I've been living in my car with my 2 kids. And tonight it was so cold that there was no way that I was going to let them sleep in the car. So I brought them in because I didn't know where else to go. And I remember hearing this story, guys, and I'm sure you all as providers have had this same feeling that I had that night that was like, I don't know what to do, but I also know I'm going to take care of you. I had no idea what the resources were, what the solution was going to be, but I knew that I could not let this woman down. So what did I do? When I'm in this position in the ED, like many of us, you call social work. But I called social work and I said, "Hey, got this woman here. No way I'm letting her go home or letting her go back to her van. She's got her 2 kids here. What do I do?" And the social worker said, "Okay, great. Well, the good thing is in Massachusetts, we are a right to shelter state. And so what that means is that we can get people into a motel or a hotel if they're a resident of this state." I said, "Great." I said, "All we need is proof of residence that she's a Mass resident." So I go and talk to her. Says, "You know, we can definitely help you. You just need to show some kind of proof of residence." "Doctor, I'm so sorry, but as I told you, I just moved here 6 months ago. I don't have proof of residence." Okay, go back to the social worker. "I'm sorry, she doesn't have anything. She doesn't have a check stub or a light or an electric bill. What do we do?" The social worker said, "Well, if she's interested in registering to vote, her voter registration counts as proof of residence in Massachusetts." Light bulb went off. Went back to the patient. I said, I can definitely help you and talk to you more about some of the resources we have. But first, I have a question for you. Are you interested in registering to vote? And her answer shocked me. I didn't know I could. No one has ever asked me if I wanted to register to vote before. And she's not alone. We have 51 million people in this country who are not registered to vote. When you ask them, "How have you been asked?" Or, you know, "We see that you're not registered to vote. Where have you been asked? In what context have you been asked to register to vote?" The vast majority of people say, "Nope, actually, I've just never been asked." 60%. People are waiting for an invitation. And so when you look at who is not registered to vote in this country, it's primarily 3 different groups: young people, poor people, people of color. I think intuitively we know that. Those are sort of disproportionately higher demographic groups that are more likely to not be registered to vote. But this is the part that I think people outside of medicine don't get. Those 3 groups are the same 3 groups that are most disenfranchised by our healthcare system, that come to me in the ER asking me to treat the rash they've had for 20 years. Because why? The real emergency is they don't have a primary care doctor in the richest country in the world. Or the real emergency is that they've been underinsured for years, or they lost their insurance. Those are the real emergencies. It turns out that folks who rely on safety net institutions like ERs, community health centers, are the same exact groups that are not registered to vote. So the question here is, yes, this is a problem, but is there an opportunity as well? And for us, we think about this as an opportunity to offer voter registration given that demographic overlap. We do that with 3 tools. 1 is our site-based tool, 2 is our Healthy Democracy Kit, 3 is our digital or telehealth work. We'll get to some of these numbers in a second, but basically we've got about 100 hospitals that are using some aspect of VoteER already, Hopkins being one of them. We're very proud of the work that Dr. Chang and Dr. Hinias have done to get you guys at least the beginning of the Healthy Democracy Kits. We'll check in on how that's going in a bit. There's about 16,000 providers across the country who've either received their Healthy Democracy Kit or will soon. But let's talk about each one of these. So this is the site-based work. It's very simple. The bottom line is here, there are no doctors or nurses walking around with voter registration paperwork. We do not have time for that, trust me. What this is, though, is a reminder for patients to register themselves to vote if they want to, in an optional way, non-coercive way, non-interruptive way, like this. We create posters like this that are specific to the hospital. So for example, this is the Children's Hospital of Philadelphia posters. Anytime someone uses these posters, we know on the back end that it happened at Children's Hospital of Philadelphia, so we can tell them at the end of the month, hey, here's how many people you got registered to vote. Here's how many people you helped vote safely by getting them a mail-in ballot. And then we create discharge paperwork like this. We used to do these kiosks. We don't do them anymore because COVID. The Healthy Democracy Kits are an entirely different thing, and were very much prompted by COVID. So the question became, in the middle, we wrote this slide back in March, actually, in the middle of really what we were going through up here in the Northeast in Boston. We had a decision: do we stop doing what we're doing, or do we figure out how to pivot and maybe realize that this is actually the exact reason why healthcare providers need to be engaging in civic engagement in a more robust way? And so the question we're trying to answer is, how do we mobilize healthcare providers in the post-COVID world, acknowledging that providers like me in the middle of March were scared that I was bringing this home to my family, scared that I was having to make decisions about who gets critical care resources and who doesn't, scared for myself, the fact that, you know, using the same N95 for 4 weeks in a row, but previous to COVID, you know, N95s were one-time use only. So there were a lot of things that were causing anger, frustration, disappointment. The question was, how do we take that and convert it and point it into a productive direction? You're upset? Cool. A tweet is not enough. Go register 3 people to vote. So how do we help people do that? We did that by creating these things, which is called a Healthy Democracy Kit. They're free. When you open the box, it tells you a story about why it's important to do voter registration. You watch a video that commits you to using it in a nonpartisan way. There's a script here that you have to sort of educate yourself on in terms of how to bring the conversation up with patients. And this is what's actually in it. They're badges and they're lanyards. So for example, like 5 or 6 days ago when I was on an overnight, a patient asked me, hey doc, why does your badge say vote on it? And I said, well, it says vote on it because if you're interested, while you're waiting here, you can register yourself to vote. Just send that text message or use that QR code. Or sometimes I bring it up with patients and I say, you know what, actually looking at your past medical history, you know, you're a post-transplant patient and you're on a couple bad immunosuppressants, I think it's probably unsafe for you to vote in person. Do you have a mail-in ballot? But you don't. Okay, cool. Use this badge and you can get your mail-in ballot. We have about 15,000 folks who've gotten these kits already or will get them soon. And the most inspiring thing, I think, is this aspect here, which is self-explanatory. George Floyd was murdered on the 25th of May. And before that date, we had really tepid growth, not a lot of interest, weeks of plateaued growth. After that date and after the protest started, we just really went into exponential growth, and we've had essentially sustained interest in this really just inspiring way. And I think the way I interpret this is healthcare providers seeing that if we're going to create a better criminal justice system, we have to do what it takes to help our country get there. And the bottom line is, one of the only ways is to make sure people are voting and participating in this democratic process. By the way, healthcare providers, like physicians vote at 10% lower rates than the average population. So, you know, we got to clean our own house up first before we start talking about other folks. So the most creative aspect of this has been the ability to customize these kits for any school or program or residency. And so what you ask would we do with something like that? We create a national competition, because why not? So we created a national competition between 50 medical schools, started August 1st, all seeing which can get the most folks registered to vote. But as you know, in medicine, you can't do anything without a pilot first. So we piloted it first with a preseason between Duke and UNC, and it lasted 10 days. Over the course of 10 days, they got over 550 people registered to vote. This is just the day one score. And I'm curious to see where Johns Hopkins is today on the medical leaderboard. Well, first of all, UPenn is just way out in front right now. Can you guys see my screen? Nope. Okay. Let me reshare here, because this for the competitive types will be triggering, I assume. This is the actual up-to-date scoreboard. So in number one is UPenn. UNC is 120. Let's check in and see where Hopkins is on the 50. Oh, not there. So if you guys know medical students that are interested, get them involved. Maryland, though, let's see. Maryland is number 12 in terms of all states doing voter registration among physicians. So great work there. Lastly, these medical students have been doing this work in really interesting ways, like going through drive-through COVID screening clinics and going with their white coats and signs that say honk if you want to register to vote, and then airdropping voter registration links to people in cars, which has been, I don't think it's ever been done before. Leave it to medical students to figure out ingenious ways to do really good things. This is the UNC medical school team. They did things like, and I'm going to pretend like I know what I'm talking about. They created Twitter storms. Don't know what that means, but apparently they were very effective. Yeah, this is no longer accurate. This is just literally 4 or 5 days ago, and you already saw the most recent score. So UPenn has doubled their score over the course of the last 4 or 5 days. Lastly, we partner with hospitals and health centers to do things like this, which is send text messages. Hi, Catherine, this is Mary from your health center. Did you know our health center can now help you get registered to vote? Please click this link and either get your mail-in ballot or register to vote. And that's pretty much it. I hope that this has been informative. I want to pass it on to the next Grand Round speaker, who will tell you about the amazing work that she's doing.
Thank you so much, Dr. Martin. So everybody should have the QR code also on their phone here, and we all need to make sure that all of our employees are registered, that we are all registered. We all need to get mail-in ballots here in Maryland. As you know, you have to request a mail-in ballot for voting in November. So use this QR code, which I also sent out in the Pediatric Pulse. We all should exercise our right to vote and encourage all of our families to do the same. So our next speaker, we are pleased to have Dr. Kathleen Page. She is an associate professor of medicine here at Johns Hopkins in the Department of Medicine. Her areas of clinical expertise include infectious diseases, HIV, AIDS, and tuberculosis. And she directs many programs and is the co-founder of Centro Sol, the Center for Salud and Opportunity for Latinos. She has been an innovator in many areas, especially in the area of care for the Latino community. And I won't go into all of those programs because there are many. She received her undergraduate degree in public health from Johns Hopkins, her MD from Washington University School of Medicine, her residency at the Hospital of the University of Pennsylvania, and performed a fellowship in infectious diseases at Johns Hopkins, joined the faculty here at Hopkins in 2006. She's been recognized with several honors, including the Mayor's Hispanic Heritage Award in the Service Provider Organization category, and it really has been a leader here in addressing the needs in the Latino community. So really happy to have Kathleen talk to us today about one of those innovations. Welcome, Kathleen.
Hi, thank you so much, Tina, and everyone for having me here today. So I don't know if I can forward the slides, so I may have someone do that for me. Is that possible? Next slide, because I'm not able to navigate the slides, sorry. Okay, thank you. And so today I will mostly speak about our experience here in Baltimore with COVID-19 and the particular impact that it's had, an unfortunate impact that it's had on our Latino community, and try to frame that in the context of also what's happening in the country. So next slide, please. So when COVID-19 emerged, many of us who were working, have been working with this community for a long time, were really quite concerned about what the impact could be. At the time, when I sat down to write this perspective, it was a time when there were shortages of testing all over the US, and people were being told, don't come to the hospital if you're sick, call your doctor, and your doctor will tell you what to do. And we knew that there were many, many people in this community, at least where we live in Baltimore, which has a large immigrant Latino community, and many of them undocumented, that many of them would not have that opportunity to call a doctor. And so we wrote this piece sort of sounding the alarm of some of the concerns that we had. And next slide, please. Unfortunately, I have to say that in even my worst nightmares, things turned out to be much, much worse than I thought. And when I think back to the time when I sat down to write that, I think some of these things felt somewhat theoretical. We thought that it could be bad, but it was really much worse, unfortunately, and really quite sadly. So I got this email from an ICU attending, I think it was April 13 or so of this year. And I'm going to read it in its entirety because I think it expresses a lot of the things that I'll talk about later. But he emailed me and said, I'm emailing you because he was concerned that he had never seen so many Latino immigrant patients in the ICU in his career at Hopkins. And he said they all seem to live in large households, continue to go to work for monetary purposes, and all describe much of their family having fevers and feeling sick. Our patient last night told me that he believes he got it from his cousin and believes his children have it as well. They all live together. He describes not having a PCP, not knowing what to do about screening and testing, but also discussed a massive hesitancy towards letting others know outside their family. From stigma to legal concerns, it is clear that unless someone needs hospital care, they are not seeking attention around COVID-19. More so when they do arrive, they are by far in worse shape than our typical patients. Only nursing home patients seem to be doing worse. Next slide. So that email triggered a whole set of meetings and sort of response that I'll try to outline. This is data from our system, which I think highlights that that disparity that this attending was referring to. And what you see in these slides are the positivity rate of COVID-19, of everyone who got COVID-19 tested in our system up to May 25th. In the sort of dark blue line on top, right here, you can see the positivity rate among Latinos. In the yellow one, you see the positivity rate among whites. And then here in the turquoise, Blacks and others. And you can see that the positivity rate for Latinos was much higher than anyone else throughout this period. For several weeks, it was over 50%. On average, during this period, it was 42%. It was 18% among African Americans and 8% among whites, so still a disparity with other communities of colors compared to whites. Next slide. And this is a map from Baltimore City, and you can see the sort of the incidence rate. And this is a month ago. Unfortunately, I went back to the website and they've changed their thing, so they didn't have this same presentation, so I couldn't update that. But this was about a month ago, and you can see the test positivity rate by different districts. You can see here 21224. This is a historically immigrant neighborhood, has had many waves of immigrants throughout the years, not only Latino, but now is mostly a Latino immigrant neighborhood. You can see the high positivity rate, the high number of cases per 1,000 residents, higher than in any other area in the city. And the testing rates really no better than in anywhere else, in case someone thought that this was only due to increased testing, as some of our leaders seem to think. Next slide. My question, of course, is this only happening in Baltimore? Is it happening in other areas of the country? And this is data from covidtracking.com. This is actually more recent. I just looked at it this weekend. And you can see here, this is just a select group of states, the percent population in the middle column, and then the percent of COVID cases that are among Latinos. And you can see that, you know, many of these states is at least twice, if not 3 times higher than what would be expected. And in some cases, even higher than what in Nebraska, it's almost 4 times higher than what would be expected by population alone. Next slide, please. The question when you look at this data is that it doesn't really tell you whether, you know, Latinos are a very heterogeneous community in the US. And there's a wide variety of both socioeconomic status, education, immigration, etc. And of course, and not of course, but the data actually does not, you know, it's hard enough to get data on race and ethnicity, and that's as far as it goes for the most part. However, you know, I was interested to see whether what we are seeing in Baltimore and in Maryland is really very dramatically impacting Latinos who are Spanish speaking, so immigrants primarily. Although Maryland does not only have an immigrant Latino population. In the rest of the country, that seems to be the case. I don't think exclusively, but certainly if you look at lay press reports, there is really a sort of an underlying sort of theme here that Latino immigrants, and particularly those who are undocumented, are being hit particularly hard. Next slide, please. So this is a study just getting a sense of the overall impact on seroprevalence. These studies are just starting to emerge. And again, you can see disparities here. This is the first, in the top I have the seroprevalence study conducted in New York State. It was done with convenient sampling. And the seroprevalence among Latinos was 29%, also high in non-Hispanic Blacks at 20%. And in whites at 8%. Indiana had a different methodology, which was more, well, it wasn't convenience, it was random selection, and so different, you know, sampling methods. It was conducted in a very short period of time, so pretty early in the pandemic. And you can see again that the prevalence, at least at that time, was almost four times higher in Hispanics and in non-Hispanics. Next slide. So the question, of course, is, you know, so we know I think it's pretty clear that at least at this stage in the pandemic, things could change as waves, second and third waves come on. But so far, Latinos have been really disproportionately impacted in terms of number of cases. The question is how serious are these cases? You know, if all these cases are mild, then although there's a disparity, you could argue, well, maybe this is not such a bad thing. However, when you start looking at mortality and hospitalizations, you see that there's also a disparity in severe cases. And here is data from New York City looking at age-adjusted COVID-associated hospitalizations by race and ethnicity. And in New York City, African Americans, non-Hispanic Blacks were really significantly impacted, as were Native Americans. But Hispanics were also highly impacted compared to whites. And I think when you look at any data for Latinos, just a comment is that it is very important to do age adjustments because it's generally a younger population. And so when you look at overall deaths, you may not see that disparity. It's really looking at the age adjusted data that will give that sense. Next slide, please. So since I was doing something in pediatrics, I figured I would at least put one slide that mentioned children. Sorry that it's so small, but only to say that the cumulative rate of hospitalizations for children and Latino children also seem to be higher than they are for whites, as well as, and also non-Hispanic Blacks are more affected than whites in terms of children who are hospitalized as severe cases. And finally, looking at age-adjusted deaths, you can see, again, this is in New York City, that Hispanics and Blacks, African Americans were much more impacted in terms of mortality compared to whites. Next slide. So this is actually something that I alluded to earlier. The Latino population actually generally in the US is younger than demographically younger than other groups. And Latino immigrants in particular are really much younger with a very small representation in the very high age groups. And so when you look at mortality, you start seeing some of these disparities, particularly around younger deaths and people. So this is a study published in MMWR looking at over 10,000 decedents charts and data. And you can see here that compared to whites, for example, here you see and let's look at the white category first, sort of the mortality, the percentage of people in the white category who died who were really old. So most of the people who died who were white were over 75 years of age. You can see here in non-white, non-Hispanics that this looks different, right? And so that proportionately more young people died in that group. And likewise, when you go to Hispanics, 35% of Hispanics and Latinos who died were younger than 65 years of age. Next slide. Okay, so what's happening and why this disparity that we're seeing in terms of number of cases and also in terms of impact, severe cases and mortality. So this is just quickly a slide from labor statistics showing that something that I think has been at the core of this is essential work and who can stay at work and who cannot. And you can see here that communities of color, in particular, Blacks and Latinos, are much less likely to be able to work at home, and that the weekly income is also lower in these communities. And again, I think it's important to recognize, and this is also the case for Blacks and other minorities, that when you look at, this is the average weekly income for all Latinos, but among the Latino population in the US, there's a wide variety of socioeconomic range, and there's some Latino groups that are specifically affected and their income is likely much lower. So next slide, please. So I think now I'm really going to pivot and talk about Latino immigrants and particularly undocumented immigrants, because again, that really was truly what we saw here in our hospital. Over 95% of the Latino patients with COVID were Spanish speaking only. And although we don't ask about immigration, the majority did not have primary care doctors, and just in looking at their insurance options, et cetera, it became apparent that many, if not the vast majority, were undocumented as well. So so let's talk a little bit about immigration policy and safety net. The safety net basically for immigrants and especially for undocumented immigrants is very slim. And this preceded this administration. One of the first sort of acts to deny undocumented immigrants for certain benefits happened in 1996 as part of the Personal Responsibility and Work Opportunity Reconciliation Act, which denied undocumented immigrants eligibility for federally public benefits. ACA, as many of you know, has exclusions for permanent residents. They have to wait for 5 years before they're eligible. Refugees and people who are seeking asylum are eligible, but those who are undocumented are not eligible. And in the US, there's 7.1 million immigrants who lack health insurance. The public charge is a rule that counts lawful use of entitlements against green card holders. So for example, parents who are undocumented, whose kids are US citizens, if their kids use certain types of benefits, not all benefits, but certain types of benefits, that could be used against them. Now, it's a very complicated ruling, and it truly doesn't affect that many people, but it's confusing, and many people, this is even before COVID, started disenrolling their children from SNAP and other benefits because they were worried that that could impact their own pathway to citizenship if it ever happened. And again, for many people, they weren't even on the road to getting a green card, but that's the, everyone, undocumented immigrants recognize that that is the best path to success and to opportunity in the US. So I think everyone dreams of that, and anything that could impact that is concerning. So in a very, very, very unfortunate turn of events, and despite many sort of court rulings, etc., the public charge did come into effect on February 24th, 2020, right as COVID-19 was coming into this country. And finally, the stimulus check, just a comment that, undocumented immigrants are not eligible for the stimulus check, they're not eligible for unemployment benefits, and those things are critical in explaining why this community has been so impacted. Next slide, please. This actually, as I said, when I sat down to write this op-ed with a perspective with Sarah, I went to public charge, and this is what comes up. So the public charge really does, using getting treated or tested for COVID-19 does not impact public charge. However, I'm not sure that many undocumented immigrants are going into this website to find this specific thing. And the impact of these rules are long-standing. You don't just turn things around in one day. So what are some of the determinants that impacted Latinos during, Latino undocumented immigrants during this period? So first of all, I'll say that in my mind, this was all about, well, not all, but many, in large part about economics and poverty. These are people who are working. They're many times working many jobs. And they have very low wages and very poor worker protection. So work is often irregular. And because of that, they often, many people are not only supporting family here, but they're supporting family back in their own country. So they live in very, very crowded housing to save money. They're obviously not getting housing benefits. The transportation to some of these work sites is very crowded, with many men being put in a van without protections, without the windows open, etc. And people, I think the issue of seeing people come in very late to care is that people are very afraid of high medical bills, and so they will not seek care unless really truly necessary. Next slide. In terms of legal, there's very few worker protections, as I mentioned. We talked about the lack of health insurance and unemployment benefits. And then there is this risk and fear of deportation and family separation. And I think that we have seen that a lot in terms of our response and trying, for example, to refer people to the Lower Baltimore Hotel for isolation. People are just very mistrustful of the system and are reluctant to go anywhere where they think this could be some type of situation with a family separated or detention, even though it's not. It's just hard to explain that and overcome those fears. And then there's language barriers, lots of stigma and discrimination in many different levels that have made this response difficult. Next slide. So this is just a diagram of the different types of things that can help or not help, and specific to, I sort of highlighted in red the policies that help or don't help that are related to this. And I won't belabor it, but because I think we went through a lot of it. There's some basic things like some states provide driver's license, sometimes some don't, and having a driver's license can really be different. Can impact COVID-19, right? So if you have a driver's license, you may be able to drive yourself to work, or you may be able to get labs more easily. Not having a banking or saving account really created a problem for people who had zero money, zero left safety net as jobs disappeared. So anyway, let's go to the next slides for time. So what have we done in the U.S. At Hopkins? So we had a pretty broad strategy with an inpatient side of things and the outpatient side of things. And I think we developed this strategy very early on without really knowing if it was going to happen. But I think all of these things have happened now. So I'm glad to report on that. The first thing we did, and we actually reached out to our friends at MGH, because their wave had also impacted Latino immigrants and had impacted them a little bit earlier. So I had learned through colleagues that they had redeployed bilingual providers to the system to help with communications, complex communications with patients, and that's the first thing we did. We also, probably the second thing, or at the same time, we set up a hotline at Esperanza Center so people without a doctor could call and get linked to testing, and that was critical, really a life really, really critical. And then now we've established expanded testing in the community, and we've worked in actually many of these things. I'll go over them in a little bit more detail. Next slide. So Juntos, some of you may have called a Juntos consult. Basically, it's a volunteer base of bilingual providers who cover a pager, and we get called to navigate complex situations. With PPE, it's very difficult to communicate the language. The interpreters were not going in person. People couldn't hear. When people come off extubation, it's a very complex period where they're confused. It's hard for them to really talk to an iPad. So we were there to help with that. We helped with tons of family meetings. We facilitated end-of-life conversations. L&D was busy. It's not busy anymore because now, thankfully, the guidelines are more clear. But we got tons of consults on trying to give the moms a choice whether to separate or not. Also did basically in some ways helped the social work team, because discharge planning for many of these patients who didn't have a doctor, who were now newly diagnosed with diabetes, etc., was complicated, and we had lots of connections in the community to create resources for the teams. Next slide. We are early on recognized that food was going to be an issue for families, and also for people who are now having to isolate because of that loss of income. So Centro Sol has distributed, I don't even know, thousands of boxes of foods to people. We worked hard with the city health department to get them to take patients in the Lord Baltimore Hotel, which you can see in the right, for people who couldn't isolate. This hotel was initially being used for street homeless people, but we just pushed hard that so many people were, really the housing conditions were something that you couldn't believe. 5 families living in a 4-bedroom household, 10 men living in a basement, and it was clear that there needed to be an alternative for isolation. So that's the Lord Baltimore Hotel. Although, like I said before, we haven't been as successful in referring people. People are very mistrustful of that. And this is our community testing site. This was launched on June 25th. At a time when actually the wave in Maryland was coming down and the hospitalizations were coming down. So it took us a long time logistically to set this up, which is another volunteer-based activity. And when it finally got approved by Kevin Sowers, I was a little embarrassed. I thought maybe we wouldn't see the positivity rate that I have been screaming about. But sadly, I was wrong. Go next slide. The positivity rate is really astronomical and continues to be. At every event we've had, it's been 35%. I think it was 30% one, and then it was 50% in the next one. But the last event we had was a few days ago, and you can see the positivity rate here among Latinos, 34.6%. Among non-Latinos, it's 3.7%. So far, we've conducted 1,300, a little bit over 1,300 tests, and about 60% or so are conducted among Latinos. People can just walk up or register, which we prefer because it creates some logistical challenges, but most people walk up, and this is what we're seeing. Next slide. Next slide. This is just getting a lot of and the only thing I say is that I do want to recognize the work of Alejandra Flores Miller, who is an outreach worker who has worked with me for a decade or more, and her team, a very small team, and they're doing an incredible job. Everyone who gets tested at this event and tests positive gets a call within 24, at the latest 48 hours, but actually our lab is wonderful and we get the results pretty quickly. She calls, or her team, they identify contacts, they link all the contacts to testing, they ensure that the person can isolate and set up food delivery. If they're not getting food delivery, refer them to the hotel if they need to be referred to the hotel. At one point, there was cash assistance available through NEMA, so she was sending up cash assistance. And it's really, I have had to step in and help because, again, we're so short-staffed, and I can tell you that one call can take over an hour because of all the contacts that live in the house, et cetera. And she and her team have really been working day and night, weekends and evenings to get this done. Next slide. I think and this is just some of the other things that we've done. We do some media, like every week we have a Ask Your Doctor show to try to get people more information. But we still have lots of challenges, as mentioned there. We can't fix poverty. We really can't undo years of anti-immigration policy. And I really think that has had a huge impact in how the community has felt very aware and apprehensive of anything that is happening. And there's a lot of rumors going out there, I think understandably, saying, because people watch the news and they hear this disparate impact on African Americans and Latinos, and the word out in the street is, it's because this is a conspiracy. You can't go to the hospital. This is they inject Latinos and immigrants, and this is a way. I have spent endless hours talking to people about this type of question that comes through these chats. So with that, I'm going to stop, and hopefully there's some room for questions.
Thank you so much, Kathleen, for all your work. I think we have two amazing examples of champions who have innovated to really ensure health equity, and wanted to get into some questions from our audience. So please go to the chat box. So I'm going to turn this to Kristen.
Oh, Kristen. Oh no, I thought it was a question.
If anyone has any questions, go ahead and put them in the chat box and I will relay them to Dr. Page. Dr. Martin did leave a message saying he had to hop off for another meeting, but gave his email address there in the chat box if anyone had any questions for him.
Thank you all very much. Please reach out. And thank you for the opportunity.
Thank you very much for being with us today.
How about a quick question before you hop off?
Yep.
I know that some people question whether this is really a partisan effort. How do you respond to that?
Yeah, I think the thing to remember is that, first of all, the law says that this is okay to do. The 1993 National Voter Registration Act made it not only legal, but encouraged for nonprofits to do voter registration. This is why we get registered to vote at the DMV, which is the most common place where this law is actually implemented. And so I guess I would ask, is it partisan to register to vote at the DMV? Is it partisan to register to vote via the USPS when they send you an updated address change parcel? When you move, you actually get a piece of mail that says register to vote. Folks register to vote at libraries. Is it partisan to register to vote at the library? So I would think about this from the sense of we have the ability to do it. Legally, it's okay to do it. And if it's done in a nonpartisan way, which it always should be when done in a hospital, patients should never be coerced or influenced. But we should offer voter registration, and whoever they want to vote for, it should not be up to us. It should be up to them, but we ought to help folks at least get started with the process. That is what we owe to them. So I guess that's what I would end with on that.
Great, thank you so much.
All right, take care, y'all.
Thank you. Dr. Page, we had a question about the census. Whether you've had any success in encouraging the community to respond to the census.
Yeah, Centro Sol, and particularly Monica, has been doing a lot of work around this. It is a labor of love. It takes a lot of foot canvassers and conversations and having, with trusted partners. And of course, COVID has complicated that. So the type of work that would have normally gone on in a massive way is still happening, but it's not in the same, it's just more difficult. And I think that's a challenge because what we hear, I think when someone who's trusted goes out, people will do it, but not so much the response that they get in the mail or, that type of thing.
Great, thank you. Any other questions? Okay.
So
Dr. Jane's going to answer a question about getting badge buddies.
So one person asked, how do we get the voter registration badge buddies? So we did order them. Actually, Marquita ordered lots of them, but as Dr. Martin showed you, a lot of people requested them. So they were able to give us enough, I believe, for all of our pediatric residents. I also sent around the QR code, and I will send that around again. So if people want to just use the QR code, you just can use that's really the QR code that you need off of the badge. So I will send that around today for people to use. It is a very simple code that you can go in and help people get registered, or have other people get the QR code. It is also a place where you could go and get an absentee ballot for yourself or for anybody else.
Great, thank you. Dr. Page, you had another question asking what problems did you anticipate as children head back to school this year?
Yeah, I don't know if they are. It sounds like they're not, unfortunately. But I think it's, and specifically for Latinx and undocumented communities, I think, so homeschooling has been very, very, very difficult for this community. Lack of technology, and also parents who are either working or also don't have the tech savvy to be able to be helping especially the younger kids. So that's been a huge challenge. In the community, like in 21224, schools are not opening right now, and they're not opening throughout, but if they were, it would be concerning because of this high positivity rate. So like you are, I think, there are these decisions that are being made at a large level, which I guess makes sense, but there are some communities where the rates are so high that I just can't imagine how you, I think I'm calling this an outbreak. It needs to be under control before they can think about opening schools with that level of positivity. But it's really, really difficult. I mean, it's difficult. I think there's probably lots of people in your audience who have small kids at home. It's not so easy, but we have many more resources. It's been really hard for these communities. Yeah, I don't have any good answers except that it's going to be difficult either way.
Thank you so much. Well, I don't see any more questions in the chat box at this time. So thank you again. This was a great grand rounds today.
Thank you. Bye-bye.